Alrighty. So we're talking about techniques associated with evaluating articular cartilage. And this just shows a case of someone who, this is the T1 weighted pre-contrast, a T1 weighted post-IV contrast. And notice that there is an area that enhances within the articular cartilage here. We'll explain what this is. This is an area of abnormal biochemistry. And one of the techniques we'll talk about to evaluate biochemistry of cartilage, we'll use IV contrast. And we'll explain why the abnormal areas enhance and the normal areas don't in a few minutes. So here's another case where we have proton density fat suppression here and here. We have a T2 weighted image in the sagittal plane here and a post-gadolinium image. What we can see is that you probably would say that there's an abnormal area of the articular cartilage here on this PD fat set. It's probably thickened with a little bit of edema with the normal cartilage up here, but you can see that the contrast for the pathology is not very good. It's a bit poor. Here we can see a little bit more contrast in this same patient on a different look here with PD fat set. Here's a T2 weighted sequence in this particular area where you have much better contrast between the normal and the pathologic articular cartilage. And here is a T1 post-gadolinium showing the enhancement of the area of the abnormal articular cartilage. What we'll find out is though most people like PD fat set or T2 weighted fat set images for evaluating articular cartilage, it turns out that it's pretty insensitive for a lot of cartilage disease. And we'll be discussing that. And then here's one of the early 3T cartilages, T1 weighted, T2 weighted, and PD fat set showing near normal articular cartilage. There's probably a little bit of signal abnormality here on the T2, which is probably an area of grade 1 chondromalacia, possibly grade 2, if there's a little bit of irregularity of the surface. And we'll talk about what the grading systems are later as well. And this is just a coronal PD fat set, again showing the pretty much normal articular cartilage, nice smooth surface, nice interface between the articular cartilage and the joint space. We do see some inhomogeneity, especially within the tibial articular cartilage, which is quite common. This can be due to microcalcifications within the cartilage, which you can see by CT, but actually there are newer MR techniques which are actually much more sensitive than CT at evaluating interstitial calcium. So what techniques can we use? We had a big list before. There were like 20 different techniques. Here are techniques which have been used and widely published in traditional imaging of patients. You can use gradient echo with fat suppression, fast spin echo T2, fast spin echo T2 with fat suppression, fast spin echo PD without fat suppression, with or without fat suppression, stir, magnetization transfer, diffusion weighting, and MR arthrography. We're going to narrow this down a bit more, really into looking at the ones that we commonly use, which is PD fat suppressed. Now, a lot of people like to use T2 fat suppressed instead. It gives a little bit better contrast for the pathology within the cartilage than PD fat set, but the signal to noise is significantly worse. And in most imaging, we've generally found over time that we have a preference for the PD fat suppression with better signal to noise than the T2 fat suppression techniques. Then there's T2, which is really good for looking at focal cartilage defects. PD fat set's good for cartilage thickness and signal intensity. And then the PD and T1 are pretty good for cartilage morphology, but the pathology is best visualized in these two techniques. This was a paper from Radiology in 2016, where the question is, well, we see a lot of signal inhomogeneity within the cartilage using these different techniques. What does this mean? So they imaged a number of patients, and they looked at, they graded the type of signal abnormality within the cartilage. And then they re-imaged them 2 years later to follow to see what happened to the cartilage in the area where there's signal abnormalities. And they graded the signal grades into focal hypointense, like we see here, inhomogeneous signal over a larger area, like we see back here, hyperintense, which we see here, and hyperintense with thickening of the articular cartilage, which we see here. So they're looking at signal changes within the cartilage, not defects within the cartilage. When they evaluated these patients 2 years earlier, is what they found is that all of these areas of cartilage progressed and worsened. Here we can see increased signal intensity at the beginning. We can see thinning of the articular cartilage and more inhomogeneity 2 years later. Focal hypodense defect at the beginning became actually a fissure on the follow-up imaging. And then here we can have more inhomogeneous signal here, which actually ended up having full thickness grade 4 cartilage defects with a little bit of underlying bone marrow edema. Thickening with increased signal intensity at the beginning became thin with inhomogeneous signal and actually a full thickness defect. So what they found is that all of these signal changes within the articular cartilage tend to progress over time. So they're probably abnormal cartilage, and we'll discuss that in more detail in a minute. And that abnormal cartilage has a tendency to worsen over time. And so now the general feeling is that early cartilage disease is really biochemical. You certainly can have young athletes who have normal cartilage, which have an injury, either a fracture or just a big impaction injury, which can produce an acute tear of the articular cartilage. But this is really rare. 99+% of the cartilage disease we see starts out as a biochemical abnormality within the articular cartilage, which progresses over time. And ways to look at the biochemical changes, what we would really like to do is be able to evaluate abnormalities early on before you have a defect at arthroscopy and before you have a mechanical defect in the articular cartilage, and then try to do something to stop its progression or to reverse its progression so that you don't go on to degenerative joint disease. Unfortunately, at this point, we don't have any good treatments to stop it. We'll talk about a few, such as ACL replacements and so forth. And therefore, there's been less of a pressure to try to develop techniques to evaluate the biochemical changes within the articular cartilage. But I think if we had really good ways to evaluate the articular cartilage injuries, there would be more of an attempt to try to intervene and keep them from progression. So it's really a cart, a horse before the cart sort of thing. But we can use T2 mapping, which is very good at looking at defects in the collagen scaffold of the articular cartilage. Ultra-short TE imaging, where you can see, which is abnormal, where you have frayed collagen fibers within the articular cartilage. T1 row technique, which basically evaluates the concentration of proteoglycans within the cartilage. And one of the first biochemical changes which occurs in these patients is you lose proteoglycans. dGemeric, which actually looks at defects in the glucosaminoglycans, which is part of the proteoglycan concentration within the articular cartilage. And then you can use sodium imaging, which looks at proteoglycan concentration. But sodium image has very poor signal to noise. Really, you would have to have a very high field scanner, such as 8T, to do this. So it's really not practical. So the ones that really come down to that we can use kind of daily is the dGemeric technique, T2 mapping, and T1 row. Recently, I had someone from hospital surgery, special surgery in New York, call me to ask if there was anyone out here that they could send patients to get dGemeric imaging. And I really couldn't find anyone in Southern California that does dGemeric imaging. This came out of Harvard, but we're going to talk about it anyway. So it begins. So let's look at the biochemistry. Well, actually, so you get disruption of the collagen, most likely. Then you get loss of proteoglycan and loss of glucosaminoglycans. The disruption of the cartilage is best seen by T2-weighted imaging and ultra-short TE imaging, loss of the proteoglycan by T1-row imaging, and the loss of glucosaminoglycans by dGemeric and contrast enhancement. So this is actually comes from a book that a chapter from a book that Hollis Potter wrote for a book that I helped edit back in 2005 on the knee. And this just shows an area where you do T2 mapping, where you have abnormal T2 signal intensity within the articular cartilage of the lateral facet of the patella in this location. Now, typically, we already talked about the structure of articular cartilage and how you should have much higher T2 on the surface and lower T2 deep below because of the way in which you have randomly oriented collagen fibers that dephase the signal deep in the cartilage, where you have a lot of water in the superficial part of the cartilage. So if you do T2 mapping, you should see a nice gradient of signal, as we see here in this normal area of the articular cartilage. When you get in areas of abnormal, you start losing this normal gradient, and here we can see that there's high T2 all the way through the articular cartilage in here near this osteochondral defect in this location. So that would be an abnormal T2 mapping, and here right over this cartilage defect we can see none of the normally striated T2 signal that we would expect to see in normal cartilage. This is very abnormal articular cartilage with disorganization. Here is abnormal articular cartilage without the striated appearance, but in this case we have a lower T2 throughout it. So this comes from a study that we published a few years ago looking on a clinical scanner at T2 mapping. We did T1-row and T2 mapping. We'll talk about T1-row in a minute. So what is T2 mapping? It's basically a sequence where you do a technique that can measure the T2 in the voxels. And you need to have high enough resolution where you can resolve the cartilage, and this is borderline resolution for that, where the signal intensity is mapped up to a number for the T2, the actual true T2 value of that particular tissue. We'll talk about what T1-row is in a minute. So with grade 3 chondromalacia, we see we don't have any normal T2 mapping and actually abnormal T1-row in the area where there's grade 4 chondromalacia, as you'd expect, because you don't have cartilage there. So this is a study that we published in the Orthopedic Journal of Sports Medicine. We looked at fat sequences of PD fat set and T2 mapping to correlate the two. We found that there was very good intra-observer agreement and very good, actually, intra-observer agreement in looking at pathology here using both techniques. When we then looked at its sensitivity compared to arthroscopy, now actually arthroscopy is not a very good technique to be as a gold standard in this kind of a study, because we're looking at our biochemistry of the articular cartilage, and arthroscopy is not a good technique to evaluate biochemistry. It just looks at the surface of the articular cartilage. So I wouldn't expect, if our techniques were perfect, I wouldn't expect a very good correlation, because the gold standard is not really a very good gold standard, but it's typically what's used in the literature. So what we actually found is that for PD fat set, the sensitivity for detecting arthroscopic abnormalities within the articular cartilage was only about a third of cases, so 37%. So proton density fat suppressed, which we use all the time to look at articular cartilage abnormalities, actually is a very insensitive technique. The specificity was fairly good at around 80%. So that if we saw an abnormality on PD fat set, it was highly likely that they would find it arthroscopically. But we'll come back to this number in a minute. There are some problems with this particular measurement. We looked at T2 mapping, the sensitivity was less, but that's actually was actually better, but it was actually less than 100%. And again, remember, T2 mapping is looking at the biochemistry of the articular cartilage. Arthroscopy is only looking at the surface structure, so you're really looking at apples and oranges here. So it's not surprising that you wouldn't get a very high correlation between the two. The specificity of T2 mapping was less than with PD FATSAT, but most false positives, which show up in the specificity for T2 mapping, were grade 1 and 2 lesions, where arthroscopy may have a very poor sensitivity for picking up these early, strictly biochemical changes. So you would expect T2 mapping to not really have a great specificity compared to arthroscopy when you're looking at biochemistry. So here's some examples in our particular study. Here was basically a normal patellar articular cartilage, and we found that we only had the resolution to actually evaluate the patella, that the femoral and tibial articular cartilages were too thin in young adults and adults to really be able to do it well. Here we can see this is the PD FATSAT. Here we can see grade 4 chondromalacia here on the T2 mapping and grade 4 chondromalacia on the PD FATSAT. So the question is there a role for T2 mapping in evaluating chondromalacia of the patella using arthroscopy as the gold standard? Intern observer agreements for PD FATSAT and T2 were very high. T2 mapping had a sensitivity of 61 and 64%. PD FATSAT had a lower sensitivity, but a higher specificity. Overall accuracy was 62% for T2 mapping, 59% for PD FATSAT. But so what this showed us is that there is a fair amount of disagreement between MR and arthroscopy. But again, why we would like to be able to develop biochemical imaging for the articular cartilage is actually to define the pathology before it's arthroscopically detectable, then develop techniques to preserve the articular cartilage so you never get to a morphological defect in the articular cartilage. So this actually is not bad news if we think that the T2 mapping is doing what we think it is. So, okay. And this is basically what we've just been talking about. But we actually found that there was a problem in doing this study, or a couple of problems. But one was the image quality for T2 mapping and T2 techniques really severely limited their use only to articular cartilage, and therefore using the standard techniques that we had at that time for clinical imaging, primarily at 1.5, but also at 3T, the image quality was just not good enough to move forward. And at that, we don't really have any good measures of how to prevent progression of disease, even if we know that there's abnormality in the biochemical, even if we know there's an abnormality in the biochemistry. But we had another problem that's actually turned out to be quite interesting. In an attempt to correlate arthroscopic grading of articular lesions with MRI, T1 row, and T2 mapping, we found that there's actually a very poor correlation between the number and locations of lesions detected by MRI compared to arthroscopy, which makes a lot of the data I just showed you questionable. So we had to figure out we would see lesions that the arthroscopist and the radiologist could confirm and quite agree on that were abnormalities on MR. But then when we correlated them with arthroscopy, we found that with arthroscopy, we couldn't see them or they mapped them into a different area. So the question then came, is arthroscopy visualizing all of the articular cartilage lesions of the femoral condyles? Because we saw a lot of lesions in the femoral condyles which arthroscopically they couldn't detect. So one of the fellows at Kerlan-Jove, the orthopedic fellows, decided to do a study where we'd take 6 cadaver knee specimens and we'd evaluate them by routine arthroscopy. Well, we'd first evaluate them by routine arthroscopy. Then he would place suture markers at the margins of the visualizable articular cartilage. Then we performed MR imaging and correlated the differences in articular cartilage visualized on arthroscopy versus articular cartilage seen at MRI and gross dissections. And then we disarticulate the knee and look at it visually at the articular cartilage. So this is kind of what he did. They went in arthroscopically in a research lab at Cedars, put in these suture anchors around the periphery of where you could see the articular cartilage. So this is just a view arthroscopically, put a suture anchor here, then measure how far out he could actually evaluate the articular cartilage using standard arthroscopy portals. And then we put it in an MR scanner, and we looked at the articular cartilage on MR scanners. And then we disarticulated the knee and looked at the articular cartilage visually. So this is basically the data. Is what they found is if you looked at the amount of articular cartilage that you could see from the suture anchors that were placed in the medial femoral condyle, the arthroscopes could see about 6 centimeters distally at a 90-degree scope and 5 centimeters on a 120-degree scope on the medial, the lateral a little bit better. But if we looked actually disarticulating the knee and looking at it when the knee opened, you could see that they could evaluate articular cartilage for significantly farther. I guess these are in millimeters. So significantly more articular cartilage was there that wasn't seen by the arthroscopist on both the medial and lateral sides. And if you compare the MR scan to the gross dissection, MR was pretty close to the gross dissection. Both MR and gross dissection saw substantially more articular cartilage than was seen at arthroscopy. In fact, more than 80% of the articular cartilage proximal to the menisci, especially posteriorly, that was seen at MRI but was not visualized by arthroscopy. So what we actually then realized is what the arthroscopist calls the posterior aspect of the knee, the central aspect and the anterior aspect of the knee aren't what we called it at all by MR. And therefore, that was the reason why we had a big discrepancy. In fact, the bulk of the articular cartilage, especially of the posterior knee, was not evaluated at all by standard arthroscopy, even when you have the ideal situation where you're dealing with a disarticulated knee rather than a full patient. And what we called posterior part of the joint space is back here where the arthroscopist couldn't visualize the articular cartilage. What the arthroscopist called the posterior part of the knee was basically that part of the articular cartilage which was adjacent to the posterior horn of the meniscus. The central part was the posterior aspect of the central articular cartilage, and the anterior aspect arthroscopically was actually even short of being adjacent to the meniscus, but in the central part of the knee here. And so this is what was called posterior, central, and anterior at arthroscopy on the lateral side, and this is on the medial side. So we found that much of the discrepancy that we had between MR and arthroscopy actually had to do with something that we didn't realize was the case, which was the limited ability for arthroscopy to evaluate the entire articular cartilage. Actually, we published this in American Journal of Rentgenology. Okay, so now let's look at a few cases. Robert, what do you think of this case?
Let's see. A 44-year-old female with knee pain after doing squats at the gym. And I see some edema, bone marrow edema, kind of far posterior medial femoral condyle.
Yep. So we see it here. And actually, if you look, there's a little bit of increased signal intensity within the articular cartilage back through here. So this is that far posterior zone, which is not Well, evaluated by standard arthroscopy. You might be able to do a posterior approach to look at this particular area, but that's really fraught with difficulties because then you're sticking things into where the vessels and nerves are. So people don't like to do that. John, do you want to comment on this?
You can do it from the lateral side or the medial side by using arthroscopes, like a needle scope, if you wish. But the problem is then you have to make another puncture for instruments if you need to do something um, surgically. It's a difficult process. That's a area that's very difficult to work in. But it's doable. It's not 100% not doable. I'd say probably 90% of the time you'll have difficulty. Maybe 80%. I can't give a number, but you can see that area. Depending on if you have a 70% scope, 70-degree scope. I'm sorry to say, not percent. You can see quite a bit around a corner. Now, what we really need is a scope that bends and instruments that bend, and then I think we'd be better off.
Okay. So here we can see the bone edema and the cartilage edema. Now, is this important? I mean, is this something that we should be concerned about? And I just want to show you, this is the point in the knee where you actually have the maximum force between the femoral condyle is often in the cutting phase, especially in something like tennis, like this, where you're going in one direction, you plant the foot, you flex the knee, and then you push off to go in the opposite direction, produce a tremendous amount of force through the knee. And when you do that, the knee is in the flexed position. So this is an area where you can actually get tremendous pressures across the articular cartilage, and therefore it's an area where you can get pathology.
Well, you also have to deal with a tibial spine, which I think causes some of the problems that we deal with osteochondritis, which you're going to talk about later.
Right. Good. Okay, Taysom.
All right, so pain with flexion and walking, 74-year-old former female athlete. So it looks like in the far posterior aspect of the medial femoral condyle, we have full thickness cartilage loss and extensive subchondral cysts and edema.
Right. Okay. And here's what it looks like in the coronal plane. So this is at least one case where we can see pathology in this location, or maybe two cases if we consider the last one. On the axial plane, this is kind of what it looks like. And here we can see this occurred on both the medial and lateral side. And this was a former high-ranking tennis player, female tennis player. And so I like to call this a far posterior lesion. The the orthopedic fellow that we worked with, like to call this a hidden lesion. And if we went back and looked through a number of MR scans, we found that about 2% of the MRIs showed lesions in this location where there was no other pathology in the knee. About 5% of the time, you'll see some pathology back in this location, but 2% it's the only abnormality on MR, and therefore it's more likely to be a symptomatic lesion in those patients. So the key findings were the radiologist and orthopedist need to agree on a common nomenclature for locating cartilage lesions if you're going to do a study or actually in clinical practice, because they want to know where these things are. The articular cartilage and posterior femoral condyles are not routinely visualized at arthroscopy, which none of us knew at that particular time. I assume that they did, and the arthroscopists really thought they were seeing a lot more than they did. And then about 5% and 2% that I just talked about. Okay, so now let's go on and talk about T2 and T1 row. So this is kind of what these colors are all artificial. You take numbers that you calculate using the technique, and then you map those numbers into color maps. I prefer grayscale maps, because color maps, there could be a minuscule difference between the numbers between the red and green, but because at that interface you assign different numbers, it makes it look like it's huge. So I think there's a lot of problems in using cartilage. This happens to be from a paper in JMRI. This shows what the gross the section looked like. And then we can see the areas of the cartilage using T2 mapping and T1 row. This would be more normal cartilage over here, but still it's not normal because we don't see the good normal gradient in the T2 mapping. In this particular study, then they looked at different grades of OA, and I think these were, to be honest with you, I forgot where they got the knees, but they must have been cadavers, but I don't remember exactly. What they found is if you do T2 mapping, you can have abnormalities with lower T2, but that the amount of change does not correlate with the degree of osteoarthritis, or osteoarthrosis. But with T1 row, there seemed to be more of a linear correlation between the degree of OA and the abnormality of the T1 row measurements. And the reason for this is that T2 mapping primarily evaluates the collagen integrity. The collagen breaks down first, and therefore what you see is all of the abnormal articular cartilages will have an abnormal T2. But even if you have minor breakdown of the collagen fibers, you can still have, if you remember that old diagram, you still have hyaluronic acid and the attachment of the proteoglycans in that area. So it's pretty easy to understand why T1 row will gradually get worse as the pathology worsens, whereas in early pathology you get a lot of collagen integrity. So that's probably the reason that you find those. This is kind of now. So let's look at another technique now to look at abnormal biochemistry. So this is just a schematic diagram. We have the type 1 collagen fibers, which if you remember are more like looping fibers that attach to the calcified zone at the bone, go up, loop over at the surface, and then back down again. That you have the hyaluronic acid, and attached to the hyaluronic acid, which weaves in and out of the different collagen fibers, you have the glucosaminoglycans, which attach to it, and then the water is pulled in and attaches to the glucosaminoglycan, which kind of blows it up like a balloon. And then you have cells here to replenish the biochemical elements here when they get damaged or depleted. So those are the gags. So another technique developed by Debbie Bernstein at Harvard, who's a PhD there, is called dGemeric, Delayed Gadolinium Enhanced MRI of Cartilage. She started her publications in the early 2000s. And what she knew, looking just at the biochemistry of articular cartilage, is that the normal glucosaminoglycans are negatively charged. So if you lose them, you lose the negative charge. And you also know that gadolinium is a negatively charged molecule. So if you have glucosaminoglycan in place, it's going to repel the contrast, and it won't enhance. But if you lose the negative charge by losing the glucosaminoglycans, the contrast is going to diffuse into that area, and it's going to cause signal changes within the articular cartilage. So that's why that focal area of abnormal cartilage, what looks normal on the T1 weighted image, enhanced with IV contrast, because that was an area where there was a deficiency of glucosaminoglycans and a deficiency of negative charges, so the contrast settled down in there. So this comes from Debbie Bernstein's publications. This is H&E histology stain showing the negatively charged glucosaminoglycans, which stay negatively, areas of loss of the glucosaminoglycans, which we see here. And then if you put in contrast and both the articular cartilage fluid as well as the bone itself, then the contrast will diffuse into areas where there's no glucosaminoglycans, but not into areas where where there are glucosaminoglycans. So you'll get increased signal intensity on T1 weighted images in the area where you have abnormal biochemistry. So this just shows the area of abnormality we saw earlier.
How long does it take for that
Oh, good, John.
to occur?
So how do we do this? So the way we do this particular technique is you first image the patient using a full MR scan and in the appropriate sequences for the articular cartilage, T1 weighted. Then you take the patient out of the scanner, you inject them with IV contrast, you exercise them for 20 minutes, and then you put them back in the articular cartilage. So it takes about 20 minutes, 20 to 40 minutes. Then you put them back in the scanner, which means...
I'm sorry, that increases the diffusion rate because now you have a pumping effect, right?
Right, exactly. That's why you need to exercise them, as we talked about before.
Right.
So, and you do this. Now, the reason it's not very popular is insurance companies don't want to pay for 2 scans. Not only is it 2 scans, but you have to give contrast and you have to have someone with the patient for 20 minutes exercising them. So it's actually a very expensive technique to do. And even though it can show where you have abnormal biochemistry within the articular cartilage, most people now, what has always driven MR, use of MR, is that it detects surgical lesions, which then drives revenue for the hospital. If you're actually detecting lesions of abnormal biochemistry, that's not surgical lesions, so that's not going to drive surgery. And at this point, we don't have any proven treatments for simply biochemical lesions of the articular cartilage. So there's not really an economic or really a practical medical reason to detect cartilage at this early stage of abnormality. On the other hand, if we really want to have a significant impact upon healthcare of the society, then we need to pick it up early and stop the progression of the disease. So when we image this, so this is just an example of some studies that she did, where you can see abnormal articular cartilage, and here's the dGemeric technique. This actually shows a measure where you measure the extent of signal change due to the contrast enhancement, and then she found out she correlated that by taking biochemical analysis of the different area of the articular cartilage, so she could actually then generate a scale where the signal intensity within the dGemeric technique correlated with the concentration of glucosaminoglycans within the articular cartilage. So here's a case that's normal. This is what a normal dGemeric technique looks like. Here is mildly abnormal, where you can see significant signal change and going from the top here of high concentration of glucosaminoglycans to moderate concentration of aminoglycans between 400 and 500 milliseconds, and then severe disease where you have marked loss of glucosaminoglycans and the T1 time is between 250 and 400 milliseconds. So you can actually quantify the biochemical changes within the articular cartilage using this particular technique. Another example where she did a number of studies where, or somebody did, I think she was involved with this, where they looked at people who had anterior cruciate ligament injuries. We know that if you have an anterior cruciate ligament injury, you're at increased risk for developing articular cartilage disease over time. It's one of the reasons why people recommend doing graft placement, though it's still not clearly shown that graft will keep this from happening. And we can see that there's abnormal signal intensity here. Here's a patient who had a meniscal tear on the medial side, but not the lateral side, and we can see the medial side has abnormal biochemistry within the articular cartilage. So on the ACL graft, it's bilateral. When you have a meniscal tear, it's just that one compartment, unilateral compartment. So we can see these early changes. And again, situation here. And there have been studies that have shown that cartilage deteriorates after you have a partial meniscectomy. This was in 2020. We already knew from earlier studies that if you do a partial meniscectomy, you increase the rate of degenerative disease of the articular cartilage. And this just shows that you could actually measure that in terms of T2 changes by using the dGemeric technique before you have morphologic changes at arthroscopy and severe degenerative disease. This is a study where they looked at dGemeric values in patients. They followed them for 6 years, and they found that patients with low dGemeric indexes, even if their cartilage surface looked intact, were marked increased risk for developing osteoarthritis 6 years later. So it does predict the development of degenerative disease of the knee. Disadvantages, we've already talked about these. You have to use contrast, you have to have delayed scanning, and it's very costly because you have to scan twice and you also have to exercise the patient. Some people feel that diffusion-weighted imaging may give similar information about glucosaminoglycan content, but diffusion-weighted imaging is also a difficult technique to do. Here's a paper in Radiology where they actually tried to quantify diffusion imaging through the articular cartilage. This is very difficult in practice to be able to get the adequate resolution in a clinical patient to be able to accurately map the diffusion through the thin articular cartilage. But in vitro studies, it's been shown to be able to measure the ultrastructure of the articular cartilage and developed early cartilage injury. But I don't think it's been developed to the point where we can get adequate resolution to be able to see patients in vivo. So that's a little bit about biochemical imaging of the cartilage. For those of you who listened to the Kurt and Job lecture that Bert Mandelbaum gave the other day, a lot of people are getting more and more interested in this because people are starting to recognize in athletes where you get the bone out lesions, that I think are lesions where you actually impact the articular surface of the femoral condyle, usually. Also, it could be the tibial plateau. But when you impact it, if the impaction is just the right amount of force, the articular cartilage can absorb it just fine because it's very pliable, but the rigid underlying trabecular bone can't, and you get trabecular microfractures, trabecular fractures, whereas the overlying articular cartilage stays intact at the beginning. But once you fracture the underlying support bone for the cartilage, you then start getting degeneration of the cartilage, which starts deep and extends to the surface and eventually ends up with a full thickness defect. So there's a lot of interest in this because these lesions are more and more picked up in young, promising athletes. So there's developing more interest in sports medicine to evaluate these and then figure out ways to treat these so that the patients don't end up with full defects, such as maybe keeping them out of sports for a longer period of time to allow the trabecular bone to heal. And they're interested now, much more interested in looking at biochemical techniques to pick these up early and try to intervene earlier on in these athletes. Okay. Robert, what do you think of this case?
All right, so we have a 16-year-old male with knee pain after basketball injury and rule out ACL tear. Let's see. I think there's maybe a little bit of subchondral edema in the lateral femoral condyle.
So maybe right in through here.
Yeah.
And then if you look at the cartilage right there, maybe there's a little high signal region.
Mm-hmm.
And you would certainly want to look at the other images. Here are the sagittal images. These are T2 images right through that area. These are this PD and T2. These are 3 millimeter thick, and we really don't see any real pathology in that area.
Right.
If we actually go to thin cut T2 cube techniques, which is a three-dimensional technique which allows us to get thin cuts there's no skip, what we can actually see is that little defect in the articular cartilage, where in the thicker cuts where you have 5 millimeter skip between them, we really can't see it. So in this particular case, T2 gives us the right contrast to see it, but if you don't have the spatial resolution, you can lose it in partial RM artifact. So we found in this particular study that one of the former fellows here was a chief officer, the first author on that T2 cube 3D imaging was more sensitive than standard imaging at looking at cartilage defects. Okay.
22-year-old male basketball player, rule out meniscal tear. At least on our two images here, I think the meniscus on the lateral side is intact, but there is a focal, full thickness chondral lesion there with subchondral edema.
Right. And here this is just a PD image, which we don't routinely perform anymore. See, there's probably an area of abnormal signal intensity within the subchondral bone, though the cartilage overlying it looks pretty intact on the PD. If we go to the T2 cube, we can see some subtle abnormality here in the articular cartilage in this particular patient. Well, that's not so
Now,
subtle.
Robert,
Go through it.
I'm sorry, Robert, what would you do with a patient like this?
What would I do? I mean, I'd probably ask him to take a break from playing basketball. Have him rest a little bit.
Well, the best thing is take the patient off weight bearing,
Mm-hmm.
put a splint on them, and wait for the pain to go away. And then maybe in the future get another MRI to see if the situation has cleared up. That's what I would do.
Sure.
Good.
And then return the patient back to activity. As long as you get effusions and pain, whether you take an MRI or not, you have to take the patient off activity like sports.
Okay, thanks, John. Natalia, what do you think of this next case? You have to take the microphone over there.
Do I have like an age or something or?
An age? Well, I'll make one up here.
Uh-huh.
This is a 35-year-old tennis player who has right knee pain. And that's actually a better history than we usually get. So when you go into sports medicine practice, give us better histories.
Okay.
Okay. So we see some subchondral bone signal abnormality here with edema, and we see a defect in the articular cartilage right through here. Okay. See the defect in the cartilage. If we go to the PD and the T2 cube, here's the PD, a little bit of signal abnormality here, some irregularity of the subchondral bone. Oops. In that case, yeah. Okay. So now when we talk about injury to the articular cartilage, we've talked already a little bit about subchondral bone injury, but you really have to realize that you can get subchondral bone injury and subchondral bone edema with still perfectly normal articular cartilage if the impaction is just the right force. So there are a lot of people, in fact, a number of the residents that come through here determine whether somebody has grade 4 chondromalacia by whether or not there's subchondral bone edema. But as we'll see when I get to it somewhere here, grades 1, 2, 3, and 4 of the articular cartilage, and we'll talk about a bunch of other ways to grade cartilage as well, are based upon the surface characteristics of the cartilage and have nothing to do with the bone. And it's certainly possible to have subchondral bone edema and have no cartilage lesion. So remember that. So you get subchondral injury. Yeah, you can get acute injury to the cartilage, and these you can have a tear or you can have delamination, where delamination is really defined as separation of the articular cartilage through the calcified zone at its attachment to the subchondral bone. So you get a separation between the subchondral bone and the cartilage, and then tears through the cartilage. Or you can get chondromalacia, which is more of a degenerative disease, which acute trauma can predispose to, either from direct trauma, from subchondral bone injury, or just chronic overuse over the years. Okay, let's see, Tayson.
Is weight loss associated with less progression of knee changes in the articular cartilage among obese and overweight patients? I would say yes.
Well, believe it or not, you're right. So this and other studies have shown that weight is associated with degenerative disease, and basically anything that increases the pressure of the articular cartilage increases risk to the articular cartilage. Trauma also, but trauma under increased pressure has a much worse effect than trauma not under increased pressure. So obesity is a risk factor for the developing of osteoarthritis and weight-bearing joints, which is not a surprise, but it's nice to have data to prove it. Okay, here we go. This just shows PD fat sat T2. These are the typical 2 sagittal sequence, which we do now over time. Here we can see patellar articular cartilage with a PD and a T2 technique. And then just more cartilage, what normal cartilages looks like. And here you can kind of see the striated appearance of the articular cartilage, but better if you do T2 mapping. Okay. Natalia, what do you think of this case?
So a 58-year-old.
I'm sorry, it's Robert's turn. Excuse me. Robert, it's your turn. Sorry.
No worries.
Got him.
We have a 58-year-old with knee pain, clicking and catching for 1 year. Let's see. I mean, there's maybe some grade 2 signal in the posterior horn of the medial meniscus, but looking at the cartilage, there you go. That's better. There's a small near full thickness defect in a posterior weight-bearing surface of the lateral femoral condyle.
Yeah. So this is the reason why we've gone to back to doing non-fat suppressed T2 rated sequences, because it's there if you go back and look at it here, but often areas of cartilage on PD fat sat will have high signal intensity, which makes the contrast between a defect and the cartilage more difficult to see. If you do T2 fat suppressed images, you'll get better contrast. But I think there are other pathologies that T2 fat suppressed imaging is not as good at. So overall, we've kind of found that the optimal way to do it is to do a PD fat sat in the sagittal plane with a regular non-fat suppressed T2. Really gives us the optimal ability to evaluate articular cartilage lesions. And I've generally found over time that if you measure the lesion on the T2, if they're full thickness lesions like this, it correlates much better with what they find at arthroscopy than if you do PD fat sat images. And I think the reason why the bulk of the papers in the literature show that MR grossly underestimates the size of lesions is because almost all the papers that have been published measure the lesions on PD fat set or T2 fat set images. And we almost always will pick up a larger lesion when we can actually see the structural abnormality with better contrast on the T2 not fat suppressed images. Okay. Natalie, what do you think here? So this is a regular X-ray.
So 47-year-old male with multiple prior surgeries.
And these things are not normal. So what do you think is the structure that sets her along here on the patella?
Cartilage.
Right, cartilage. So this is calcification in the cartilage, which is called chondrocalcinosis. On an MR examination, sometimes it can be subtle to see with our standard techniques, but in this case, we can see the inhomogeneity that goes along with chondrocalcinosis in this particular patient. And as we saw before, there are at least some studies to show that areas of low signal like this are areas where you tend to get progression of cartilage loss over time. So it is a risk factor. There are now, well, I already said it, there are now MR techniques which are much more sensitive for detecting calcium within the cartilage using very ultra short TE techniques or zero TE techniques than even CT. But we're not going to go into those in this lecture. So let's stop here and we'll start up talking about some critical concepts of bone injury on the next lecture. Okay, any questions?
So, you know, there's a lot of times that we get like a pre and post contrast in the MRI,
Yes.
for example. Should we ever be looking at the post contrast and making a note that there is some increased enhancement within those
Yes.
cartilages, even with an intact overlying?
Yeah, I think you should.
Okay.
I don't think, I think there are, except for known soft tissue masses, I don't really think there's ever a medical reason to do with and without contrast.
Yeah.
Or soft tissue masses or infection are really the two indications. Almost always when we get those orders, I think it's for someone who doesn't understand how to order an MR examination, and they're ordering the wrong study. And it's not insignificant. If we go into the physics lecture this year, if you guys want to, we can talk a little bit about contrast, and there are there are risks of contrast injection that, which makes it not completely innocuous, though it's still pretty safe.
Okay.
Any other questions?
That's it.
Thanks.
All right. Thank you.
Thank you.
Have a good one, everybody.
All right. Thanks.
Thanks, John.
I'm like, so ready to